Okay, great. Yeah, thanks so much, Angela, for the introduction. I'm pretty excited to be speaking at this emerging intelligence/agentic AI in medicine sub-portion of AI plus health, um, because I think it really allows me to work with clinicians directly, and you'll see more of what that means when I show you the kinds of clinical hypotheses I'm generating at scale. So yeah, the title of my talk is Scaling Clinical Science. So yeah, that might be confusing to someone outside of computer science, but hopefully you'll get a flavor for it during this talk. And I'm going to be using two kind of new technologies. The first one is medical foundation models. These are these big models which understand a lot about medicine. And then something even newer called mechanistic interpretability, which is how we understand what the models are doing. And we're going to be using that to extract their knowledge at scale. So I just added a slide for a bit about who I am. So I started out in London at Imperial College, actually, with Martin Menton and Professor Daniel Ruckert. I moved to Munich for a couple of years, and now I've joined Stanford University as a postdoc in the AMI lab with Sergios Gatidis and Professor Akshay Chowdhury. So yeah, very excited to be at Stanford. So let's think about, before we think about hypothesis generation and basically creating new knowledge automatically, we need to think about the data that we're using. So, as I mentioned, Stanford is an exciting place to be because the radiology data alone here is 1.8 petabytes of data. So, I think the raw potential for discovering like new clinical hypotheses about why people develop disease at scale is really it's a big opportunity here. And it's not just radiology data. We also have labs data, there's clinical notes, there's just so much multimodal information. And it's also really difficult for any human clinician to go through all of this data at scale to work out if there's any kind of new scientific novel hypotheses about why people develop disease. So the basic task that I set myself at the start of my postdoc was, can we build a method that finds hypotheses that link these observations, these multimodal longitudinal patient information, to these outcomes? So why people develop cardiovascular disease, cancer, and so on. So it should be very agnostic of any of these types of data and outcomes. So, a lot of the way that people try and generate novel ideas in the kind of agentic era is by just copy pasting stuff into ChatGPT and seeing what it says. So you can imagine there's a few issues with that. So let's think about if we were to do that in our data set. So in the data set that I'll be looking at today, we have 15,000 radiology reports, and these are abdominal CT radiology reports. They talk about things, the liver is diseased and so on. It's from an abdominal CT scan. So if you total up all the words across all of these radiology reports, you get over 4.5 million words. And actually, when we talk about tokens in language models, that's over 6 million tokens. So you can imagine this is difficult for a human to look at all at once for novel hypotheses. It's actually impossible for ChatGPT as well, because it's just too much text. If you try and copy paste this into ChatGPT, it will say prompt is too long and it will basically reject you. So yeah, you could copy paste that in and say, please find all new hypotheses within this data. But yeah, as I said, the data set's far too large. And also ChatGPT might say some things like, oh, I found this novel hypothesis for dementia, due to calcifications and so on. But it's not using any statistics to back up its conclusions. It's just using next token prediction, right? This kind of autocomplete way that ChatGPT works. And we also know from our experiences with ChatGPT that it's sycophantic. So it might just claim to create a new discovery and kind of laud you for your efforts, but it might actually be completely false, and it might hallucinate things. So we don't want to use this kind of method to discover new clinical hypotheses at scale. I'm going to be doing something else using, as I mentioned in the beginning, foundation models. So foundation models have been trained on a large amount of data, often it's imaging data or text data, and they know a lot about the world that we maybe don't even know what they know, right? So you can imagine taking all of these radiology reports and instead using a foundation model. So this foundation model I'm using is called Qwen3. It's a Chinese language model that embeds information into vectors. And you can run this locally on your computer, so you don't need to use the cloud or anything. So this is a bit different. The output is no longer text. It's actually an embedding per report. And this embedding contains some information about the original report. But we actually don't know what that information is. So if you collect all these embeddings together, you get something called a feature space or a vector database. These are becoming increasingly common in document kind of lookup software and so on. And the idea is that even though a human can't actually directly understand what these vectors are, it contains really meaningful signal for things that we care about. So if I take this vector database and I try to predict if someone is going to get, for example, abdominal cancer, or if they're going to get chronic kidney disease, we can actually do this with a very high degree of accuracy, given that it's a 3-year prognostic prediction, and this is a very hard task. And we would describe that as an emergent capability of Qwen, because this language model was not trained to do prognostic tasks. It was just trained to embed documents. But in doing so, it's learned lots of features about medicine and so on. So it knows something that we maybe don't, right? So the broad outline for what we're going to do to generate these hypotheses is we're going to take that massive load of multimodal longitudinal patient data that's very hard for a human to comprehend. We're going to take these new foundation models that are capable of digesting all of that information into a vector database. And then we're going to try and learn what this foundation model knows about this big data. To that end, we're going to build a scalable hypothesis space. So this is literally just a series of hypotheses that you can rank, you can look through, you can see if they're generalized to different institutions, you can see what they relate to, and then we're going to see what we discover as a result of this entire process. So I guess just a tiny bit of background first. I know maybe not everyone here is familiar with like machine learning technical concepts, but it's I think there's some nice intuition here. So this vector database I was talking about, where every single radiology report is expressed by a set of features or embeddings that we don't understand, looks something like this. It's a kind of garbled mess of numbers that is very hard to comprehend, but it still has a signal for diagnostic tasks. We're then applying this even newer technology called mechanistic interpretability or sparse autoencoders. And what this does is it takes those very abstract foundation model features and converts them into much simpler so-called monosemantic or singular meaning type features. So whereas before, F1, F2, all these different features, they might have very strange, uninterpretable meanings to humans. These new features, these concepts, S1, S2 up to 49, these should be theoretically something much more understandable. For example, S48 might be calcifications and S2 might be liver cirrhosis or something like that. So you don't need to understand this process. The only thing you need to grasp is that we're moving from a very abstract feature space to a quite discrete concept space. So these are the concepts or ideas that the machine model, like this foundation model, has about our radiology data. And we check that this new kind of concept space retains all of the old properties, for example, the being able to predict cancer and so on. So it's getting progressively more human. I've tried to indicate that with these like increasingly human robots here. It's getting progressively more human, but we still don't understand what these machine concepts are until we start checking them for prognostic value. So, as I said, these concepts can allude to different clinical things that you might think about. And before we even know what they are, we can begin with statistics to check if they have any prognostic value. So we might find that this node here is, patients with this node activating might be highly at risk of primary abdominal cancer. So if we were to look at any one of these nodes, perhaps the highest ranking one, we can actually discover what the node means. So in this case, this node is cirrhotic liver morphology and varices, and it has an extremely high, well, relatively extremely high odds ratio for onset of primary cancer. So this is how we form hypotheses in our system. We first learn what concepts the machine learning model is using, and then we link it to real clinical concepts to understand and translate that machine concept into a human concept. In this case, this hypothesis, cirrhotic liver morphology and varices for abdominal cancer, was actually already known in the literature. So we can also rate how well our hypotheses have already been discovered or if they're actually new. And I'll be doing some of that later. So it's very important when you're generating hypotheses to make sure that you've learned something real and not some spurious kind of correlation. We also know that machine learning models can hallucinate and so on. So it's really good to check that hypotheses translate. That's the real test of new knowledge, right? That it generalizes to different places. So just a word on how we score these hypotheses. Firstly, we calculate an odds ratio. So again, think about the liver cirrhosis for abdominal cancer. We calculate odds ratio, of developing the disease versus the control group, and we normalize this by the standard deviation of the hypothesis itself. And then we also control for patient age and sex. This is very important to work out if there's a confounder and your hypothesis is simply just predicting if the patient is old. And of course, we know age is the primary risk factor for most diseases. We then test if our hypothesis generalizes to new institutions. So firstly, we're discovering all of these hypotheses within the Stanford discovery set. And then we test straight out of the box if that hypothesis works at the internal test set. So this is a portion of the population of patients that we've separated for this testing process. And this would be enough to tell, okay, maybe within Stanford Hospital that this hypothesis is useful. But we want to go beyond that, and we want to see if our hypotheses start to generalize to different institutions. So in this case, we actually go to Tri-Valley, and because it's all computed and automated, we can very quickly test our hypothesis at this different patient population. So, we might get unlucky and find that actually this hypothesis is not reproduced. So the odds ratio might go down to 1. And this might be if it's something about the clinical workflow at Stanford. Perhaps the hypothesis is just finding patients who've already had a lab test, and those people the clinician already thinks are going to get abdominal cancer and so on. Or we might find something that retains its odds ratio and the hypothesis is very strong. So again, I've got a big table here, but I'll walk you through it. So here I'm talking about the number of hypotheses that we find that actually pass this test, that generalize to a different institution. So in this case, we have 8 different algorithms for producing these hypothesis spaces that I mentioned in the beginning, that kind of node graph. And you can see some methods produce more hypotheses than others, but actually we find that one of the methods that produces the least hypotheses has the most that generalize. So it's kind of more accurate in producing hypotheses. In this case, we're just looking at this approach for producing a hypothesis space using something called Matryoshka, sparse autoencoders, and a top K value of 40. Again, you don't need to understand that to understand the rest of the results. And in this case, we found that of all the odds ratios at Stanford that were more than 1.2, 5 of those were successfully also more than 1.2 at Tri-Valley. So these translated. So what are these hypotheses? It begs the question. So the top one we found was, again, I've been alluding to it, but this cirrhotic liver morphology and varices being associated with a higher risk of developing primary abdominal cancer. So just to motivate how we got here, this hypothesis was ranked 1 within the discovery set. And this is great, but it's not enough to show that it actually generalizes. So, firstly, let's look at the, sorry, I slightly skipped it. We'll go back. We'll go in reverse order. So within the internal test set that I mentioned, it retained its rank. So out of 3,300 hypotheses that we generated for why people develop abdominal cancer, it was ranked 4. So it's very highly ranked. And the odds ratio is dropping slightly, which is a bit worrying. But actually, when we go to Tri-Valley Hospital, we find not only is the rank retained, but the odds ratio actually increases again. So whatever this hypothesis is, it's something generalizable, and that's a good thing. So let's have a look at how this hypothesis really works. So on the x-axis here on this plot, I have the degree of this hypothesis being true, i.e. the degree of cirrhotic liver morphology and varices in these patients. Each bin has 45 people. And you can see on the y-axis is the percentage of those people who go on to develop abdominal cancer. Now, the base rate of doing that within 3 years in our data set is only 3%. But actually, if you're in the highest bins of this hypothesis being true, it goes up to 40%. So the odds ratio would be something more like 12 or 13 in people with the most cirrhotic liver morphology and varices. So these hypotheses are not just binary, yes or no, they actually scale. And this is also a nice aspect of doing this all with machine learning, is you get that for free. So we've already talked about the ranking of this hypothesis. It topped 0.1% in all places that we checked it. But now it's really good to check, again, let's just check the text and make sure these people really have this feature. In this case, yes, like for example, here's a 49-year-old male who developed abdominal cancer in 1 year and 9 months. It's the first instance of cancer for this person recorded at Stanford. And they had liver cirrhosis and prominent varices throughout. Again, we can find the same thing in a 52-year-old female. And if you check all of these patients, they all essentially have this cirrhotic liver morphology and this vasculature with varices. And as I mentioned before, this has already been discovered. And I would say this is not a bad thing that's already been discovered. It's actually a good proof of concept that our method is discovering stuff which is, which clinicians have already found. I have one more hypothesis before we expand our search beyond just abdominal cancer. But this one I think is less interesting because it's more generic. It just says pancreatic pathology. So this kind of hints that, these hypotheses are really cool, but sometimes they're too generally defined. For example, here it's not talking about anything super specific. It's saying it could be anything from cystic neoplasms to solid masses, pancreatitis, and so on. Essentially, your pancreas is in a very diseased state. And if you're wondering what was the top ranked hypothesis at Tri-Valley for abdominal cancer, it was this one. So we found at Stanford, actually, the liver cirrhosis was worse. At Tri-Valley, the pancreatic pathology was worse. So, there's some random noise in that. But you can at least see that our system is producing reasonable, plausible hypotheses that generalize. And again, you can go back to the patients and check, right? Does this person have, what the hypothesis claimed? In this case, these patients do have a pancreatic atrophy and so on, and lesions. Again, not everyone develops abdominal cancer, but the rate is much, much higher than the control population. You can also compare these things. We're back to the cirrhotic liver morphology, and I'm comparing directly to other clinical risk factors like patient age and sex, and you can see it's got a dramatically higher odds ratio for predicting if the patient will develop abdominal cancer within 3 years. Cool. So this is kind of the second part now of the talk. So I've been showing you hypotheses generated from one modality, radiology reports, for why people develop abdominal cancer. Now we're actually going to expand. So we're going to expand firstly the outcomes. We're now looking at everything from chronic kidney disease, cardiovascular disease to dementia, osteoporosis, and so on. And not only are we expanding the outcomes, but we're also expanding the data source. So we were just looking at radiology reports, which is great for finding things that people have already written down, right? Because every feature in a radiology report is something that a human has actually documented. But we might also be interested in finding hypotheses in more objective data rather than subjective. So is there a new imaging feature which people had not thought of? Is there a new pattern in labs data that people have not considered being prognostic? So we're expanding in these two dimensions. And that's really I think the elegance of this method is that it does not care what the input data is or what the outcomes are. You just define that yourself and it generates hypotheses. In this case, using the same table as before, we actually get far more hypotheses using this method, right? Because we've expanded. So the number of hypotheses that generalize is much higher. We can also see, even though we're generating more hypotheses, the chance that they actually generalize actually also increases. So it's not like we're just generating lots of rubbish and some of it generalizes. Actually, these stronger hypothesis spaces, each hypothesis has a stronger chance of actually working at Tri-Valley compared to some of the weaker hypothesis spaces, as indicated by the increased percentages over here. Now, I think to round out the talk, we're going to look at one of these hypotheses from the expanded set. In this case, I think I'm still working on this one. So in this case, it's a labs-derived hypothesis. So we've basically compressed the entire history of the patient's labs data into a single embedding, and now we're trying to find novel signals for dementia. And I think this is a nice opportunistic task because most of these people are not getting labs for dementia. So in this case, the hypothesis claims to be hypoalbumin. I tried to practice this word before I got here. This is part of the thing hypothesis generation as a non-medical expert, is that I'm finding stuff and I need clinicians to review it with me because I don't know what these things are. So essentially, I kind of ChatGPT'd this that this indicates that you're low on protein, and this anemia, of course, indicates that you're low on something to do with blood. And this combination is basically giving an increased risk of developing dementia. So again, we found this hypothesis ranked very highly in the train set. That's why we first considered it. And then when we tested it out of the box at the test set, it still does quite well. And also at Tri-Valley, it's still doing well. So this is something which actually generalizes. And when we look at some of these patients, yes, we do see like reduced hemoglobin and so on, and also reduced protein in most of them. And I think this is a somewhat plausible hypothesis. I also did some Googling because these are generalized kind of issues with your vascular system, that you're not getting enough blood to the brain perhaps, and there's not enough protein to do repairs. Again, I'm not an expert and I need domain experts to interpret these things and help me take them from generated hypotheses to actual clinically useful knowledge. So yeah, as I mentioned, I've generated loads of hypotheses, and I also have a website. So right now, this is actually not public, but you can actually scroll through all the hypotheses. So even for diagnoses, for example, Anasaka, we know why people get Anasaka, but for example, cancer anywhere, again, this liver cirrhosis is very high. Also, things like portal vein thrombosis and the presence of varices again. So you can see the same features sometimes coming up. And this is how I went through all my hypotheses. I need some way of digesting all of these hypotheses. You can see one here for cardiovascular disease that focuses on atherosclerosis. So a lot of them make sense, and some of them are quite new. So yeah, I guess I have another couple of minutes perhaps, or am I really over time? Yeah. So this is the website. I actually generated a paper automatically for a cancer hypothesis, and submitted it to James Zhu's Agents for Science conference, which is obviously very on theme. And it was awarded a spotlight presentation. So I got top 5, all these rankings, top 5 out of 250. And I think for me, this was very exciting because it was the first example of a successful, instance of this scalable science for me. And we're now building this whole process out into a tool. So you should just be able to import this tool, define your data, define your outcomes, and start generating hypotheses. And it will show you a website on your own data. And you can even start publishing hypotheses with the help of this machine learning kind of tool. So you can go to this GitHub, which is still being built, but you can also reach out to me at robbie.holland@stanford.edu if you want to get in touch. I'm really excited to work with other people on their data and help them find hypotheses. And I want to build more stories of this working in different data sets, different domains. Again, it can use any input, any output. So you can probably find a way to apply it to your data too. So thank you very much.
Robbie, this was amazing. I had no idea that you were so keen on, well, first of all, we're already getting questions in the audience about how
Right.
they can get their hands on your website,
Sure.
just to point it out. Do you
Yeah,
want to
so
say that
so,
first?
so the website is still in its infancy. It's mostly a developer thing for me to review my own hypotheses. However, if you have a Stanford Gmail, you can access it. So get in touch with me for that. Also, the open source tool, which should be rolling out pretty soon. I'm sad it's not available already, but we want to make it good. That will generate a website for you on your own data, so you can scroll through it. So
Absolutely amazing.
yeah.
Well, the second question we got is again from the audience. Do you think in the future people can plug their health metrics into your system of
Yeah.
combination of LLM and other mechanisms and a foundation model, and then that will create or allow them to see their personalized odds of developing a disease?
Yeah, so I think that there's a couple things here. Firstly, this system is meant to produce new, potentially correct hypotheses, right? So I think it's more for communities. If you have a community of people, they can upload their data and it can spot patterns.
Oh,
Of course, if you're an individual, you could find an existing set of hypotheses and see if you match any of these.
ah.
But again, this is more for clinical researchers right now to extract new knowledge. And I think I would be very cautious of any individual just uploading their health data and looking at what all of these unvalidated yet interesting hypotheses.
I appreciate the caution.